Good morning. Today I'll be speaking about Achalasia cardia. Objectives of this particular presentation are the review the ethopathogenesis of Achalasia, discuss the clinical features of Achalasia, discussing the workup of a patient with Achalasia, discuss the current options for the management of Achalasia, and describe a new development in the treatment of Achalasia. History of Achalasia. In 1913, Ernest Heller performed the first surgical intervention for Achalasia, and the procedure still is known as Heller's cardiomyotomy. It was not actually called as Achalasia until a 1927 article by Arthur Hurst. The treatment of Achalasia of the cardia, so-called cardiospasm. Achalasia is Greek for lack of relaxation. Ellis et al. Described the first transthoracic approach for a patient with Achalasia in 1958. History of Achalasia. The first laparoscopic Heller's cardiomyotomy was performed by Sir Alfred Coucheri in the year 1991. What is Achalasia? Achalasia is the aperistalsis of the esophageal body, hypertonic lower esophageal sphincter due to degeneration of the neurons of the esophageal wall, and it is the second most common benign disorder of the esophagus requiring surgical intervention. Histopathology of Achalasia. Histological examination shows a decrease in the neurons of the myotomic plexus, that is the Auerbach's plexus. There is preferential decrease in the nitric oxide producing cells. These contribute to the lower esophageal sphincter relaxation. There is a relative sparing of the cholinergic neurons responsible for maintaining the tone of the lower esophageal sphincter. Histopathology of Achalasia. The loss of these inhibitory neurons leads to an increased resting tone in the lower esophageal sphincter, which also leads to aperistalsis of the esophagus. Etiology of Achalasia. While primary Achalasia is considered idiopathic, there are a few other theories. HLA-DQW1 has been shown to be associated with Achalasia and the presence of anti-myotic antibodies, which leads for some to propose that Achalasia may be an autoimmune disorder. Some have shown an association with chronic herpes zoster or measles infection. T-cell evaluation of patients with Achalasia has shown a reactivity to herpes simplex virus 1, which may suggest that Achalasia can be due to herpes simplex virus 1 infection. Secondary Achalasia can be due to Chagas disease. Chagas disease occurs mainly in the Central and South America. It is due to an infection by the protozoan parasite Trypanosoma cruzi, which is carried by Rhodnius prolixus. Infection results in the loss of the ganglions in the Auerbach's plexus or the myotomic plexus. This is the tick that carries the Trypanosoma cruzi. When evaluating patients for Achalasia, it is important to rule out the possibility of malignancy, which can mimic Achalasia. The things that might suggest malignancy are presence of symptoms for less than 6 months, onset after the age of 60 years, excessive weight loss, difficulty in passing the scope across the gastroesophageal junction. The incidence of Achalasia is about 1.6 per 1 lakh people. The relative infrequency of the disease has made it more difficult to study in comparison to more common disease processes. It occurs equally in men and women. It usually occurs in individual ages between 20 to 50 years of age. The most common clinical manifestations of Achalasia are dysphagia to foods. Greater than 90% of the patients present with dysphagia for solids, and greater than 80% of the patient present with dysphagia for liquids. The other motility disorders of the esophagus may also have dysphagia, but not with the frequency of Achalasia. There is mild weight loss, usually less than 10 kgs, regurgitation, chest pain, heartburn. Patients may sense a lump in their throat, and patient might also present with hiccups. The diagnosis of Achalasia. The onset of symptoms is slow and gradual. The average time between onset of symptoms and diagnosis is over 4 years. In patients with suspected Achalasia, there are 3 important tools in diagnosing Achalasia: barium swallow, endoscopy, and manometry. Barium swallow is an excellent tool in the diagnosis of Achalasia. Classic appearance shows a dilated esophagus which appears to taper to a classic bird's beak appearance. The diagnostic accuracy of a barium swallow was about 95% in one of the studies. These barium swallows showed a dilated lower esophagus with narrowing at the level of the esophageal sphincter, that is bird's beak appearance. There are 3 classical findings in a manometry. There is an elevated resting lower esophageal pressure of above 45 millimeters of mercury. There is an incomplete relaxation of the lower esophageal sphincter. The pressure at the lower esophageal sphincter should drop to about less than 8 millimeters of mercury normally. In achalasia, lower esophageal sphincter relaxation in response to a swallow may be incomplete or absent. Aperistalsis of the esophagus. A swallow may have no corresponding esophageal contractions. Alternatively, there may be simultaneous contractions. While the contractions are classically low amplitude, there is a subset of patients who have high amplitude simultaneous contractions. This has been termed as vigorous achalasia. All patients with suspected achalasia should undergo endoscopy to rule out malignancy. On entering the esophagus, it is usually large and will potentially have retained food. While the lower esophageal sphincter does not open spontaneously, it can be passed with gentle pressure. These pictures showed an endoscopic picture of the patient with achalasia cardia. The first diagram shows the lower esophageal sphincter, which does not open spontaneously. And the second picture shows food residue, and the third picture shows a dilated lower esophageal portion. Additional modalities such as CT scan or endoscopic ultrasound can be helpful in the workup of a patient for achalasia if another cause is suspected, such as a malignancy. The various treatment options include medical therapy with calcium channel blockers or nitrates. They are taken 10 to 30 minutes before every meal. While they have been shown to have moderate success, they require the patient to take them perpetually or lifelong. They are not recommended as a first-line therapy. Botulinum neurotoxin type A. It inhibits the release of acetylcholine. The idea for the use of BOTOX came from an understanding of the pathophysiology of achalasia. By blocking the release of acetylcholine from the presynaptic channels in the ganglia of the Auerbach's plexus, the theory is that the balance of neurotransmitters is restored, thus resulting in the relaxation of the lower esophageal sphincter, but such patients usually present with symptoms of GERD on a later date, and it is not a permanent modality of treatment and requires repeated injections. Injection is done in the area of the lower esophageal sphincter. It is administered endoscopically. The standard technique is to inject 1 ml, that is about 20 to 25 units of botulinum toxin per ml, into each of 4 quadrants approximately 1 centimeter above the Z line. The various complications include mediastinitis, esophageal mucosal ulceration, and pneumothorax. This picture shows the injection of botulinum toxin in 4 quadrants about 1 centimeter above the Z line. About 20 to 50 units of botulinum A toxin per ml is injected into 4 quadrants, resulting in reduction of the acetylcholine release and relaxation of the lower esophageal sphincter. It has a downside of not being as effective as other interventions. While studies have reported symptomatic relief as high as 90% after a few months, the effect generally falls to 50% or lower at 1 year and continue to diminish after that. The current consensus on BOTOX is that it should only be used in patients who are not fit for other interventions such as surgery or endoscopic procedures. Pneumatic dilatation. It is considered the most effective non-surgical treatment of achalasia. It involves the passing of a pneumatic device to the lower esophageal sphincter using both endoscopy and fluoroscopy to properly place the balloon. The balloon is inflated to a pressure between 7 to 15 pascals. Patients are usually observed for about 6 hours and then discharged home. The balloon is placed at the level of the lower esophageal sphincter, both endoscopically and fluoroscopically, having a look at it, and the pressure inside the balloon is increased to about 5 to 7 pascals, and then it is maintained for about 3 to 4 minutes, and the patient is observed for about 6 hours post procedure and then later discharged. The two best predictors of success post-dilatation are post-dilatation pressure, or some report the difference between pre and post-dilatation pressures, and older age. The biggest concern with pneumatic dilatation is esophageal perforation, which has been reported to be as low as 1.6%, while other studies have reported an incidence of about 10%. One study reported about 21% perforation rate. Heller's myotomy. It was first described by Ernest Heller in 1913, where he used an abdominal approach to perform an anterior and posterior esophagomyotomy. Surgical therapy now involves usually performing only an anterior myotomy via either an abdominal or a thoracic approach. In addition to laparoscopic myotomy, thoracoscopic myotomy has also been described. thoracic approach does have certain drawbacks of higher mortality and morbidity when compared to abdominal cardiomyotomy. At this point in time, laparoscopic myotomy is considered the gold standard procedure. When compared to open techniques, similar rates of complications with much shorter hospital stay and recovery times have been reported with laparoscopic Heller's myotomy. In performing Heller's myotomy, there are a few important questions to consider. Should one perform a fundoplication post procedure? If so, what kind of fundoplication has to be produced? What to do with the sigmoid esophagus? The length of the myotomy and any benefit while using a robot or not. 30% of patients complain of significant heartburn and gastroesophageal reflux disorder post cardiomyotomy. 24-hour pH probe or endoscopy has demonstrated that 60% of these patients had significant reflux. The objective analysis reveals an unacceptable rate of GERD in laparoscopic Heller's cardiomyotomy without an anti-reflux procedure. Therefore, a fundoplication is recommended in patients undergoing a Heller's cardiomyotomy. Okay, now that you decided to perform a fundoplication, what type of a fundoplication should be performed? Should a DORS fundoplication be performed or a Toupet fundoplication should be performed? What is DORS fundoplication? DORS fundoplication is an anterior 180-degree wrap. What is Toupet fundoplication? Toupet fundoplication is a posterior 270-degree wrap. This shows a DORS fundoplication, that is a 180-degree anterior wrap. And this shows a two-phase fundoplication, a 270-degree posterior wrap, wherein the fundus of the esophagus is sutured to the esophagus. There is no significant difference in the outcome between DORS and Toupet fundoplication. When you look at the outcome pertaining to dysphagia or gastroesophageal reflux disorder and the use of proton pump inhibitors. To date, there have been no randomized controlled trials comparing these two procedures. Moving on to sigmoid esophagus. What happens in sigmoid esophagus? It is a result of a long-standing achalasia wherein the distal esophagus is dilated with tortuous angulated shape, just looking like the sigmoid colon. It was previously believed that this would require esophagectomy or at the very least preclude fundoplication. Often quoted as needing 5 cm of esophageal myotomy with 1 cm of myotomy onto the cardia. Long-term outcomes confirm the superior efficacy of extended Heller's cardiomyotomy with Toupet fundoplication for achalasia, as published in an article in 2007 from Surgical Endoscopy by Wright et al. From the University of Washington, who performed a retrospective review and not a prospective review. Laparoscopic Heller's cardiomyotomy for achalasia facilitated by robotic assistance was first published in an article in 2006 from Surgical Endoscopy and was published by Galvani et al. From the University of Illinois, Chicago. It showed to be effective and safe as a laparoscopic Heller's myotomy. Submucosal endoscopic esophageal myotomy is a novel experimental approach for the treatment of achalasia, which was published in Endoscopy in the year 2007. It has also been referred to as POEM, which is an abbreviation for peroral endoscopic myotomy. It is considered a form of nodes. What is nodes? Normal orifice transcentral surgeries. The leading expert in this technique is Dr. Haruhiro Inoue from Showa University in northern Yokohama Hospital in Japan. He's performed over 100 procedures. It is started by entering the submucosal space approximately 15 centimeters above the gastroesophageal junction. It uses an endoscope with a special transparent cap. Using a solution of saline with indigo dye, a tunnel dissection is carried distally to about 2 centimeters past the gastroesophageal junction. Then a myotomy is begun, starting 10 centimeters proximal to the gastroesophageal junction. Myotomy is carried distally down to 2 centimeters past the gastroesophageal junction. Myotomy takes only the inner circular fibers while leaving the outer longitudinal fibers intact. At the end of the procedure, the scope is removed from the submucosal tunnel and the entry site is closed with endoscopic clips. This is a pictorial representation of a person performing a per-oral endoscopic myotomy, where in the first picture shows the beginning of the submucosal tunneling about 10 centimeters above the gastroesophageal junction, wherein saline and indigo dye is being injected. A submucosal tunnel is formed and continued until 2 centimeters below the gastroesophageal junction, and then a cardiomyotomy is performed from about 10 centimeters above the gastroesophageal junction, wherein only the circular fibers, the inner circular fibers of the esophagus are divided and continued up to 2 centimeters below the gastroesophageal junction. And then the scope is withdrawn and clips are placed to close the submucosal tunnel. This is an algorithm for the treatment of achalasia, wherein you have both medical and surgical managements. Medical management includes nitrates and calcium channel blockers and botulinum A toxin injection. Surgical therapy includes non-surgical therapy of pneumatic dilatation and Heller's myotomy. Let's summarize this entire presentation. What is achalasia? Achalasia is a process that affects the myotic plexus of the esophagus, leading to high resting lower esophageal sphincter pressures and esophageal aperistalsis. Medical therapy is ineffective. Botulinum toxin should be reserved for patients who are not able to undergo other interventions such as laparoscopic Heller's cardiomyotomy or per-oral endoscopic myotomy. Pneumatic dilatation is very effective but has the risk of associated perforation. Laparoscopic Heller's myotomy has excellent results. It should always be accompanied by either DORS or Toupet fundoplication, but not a Nissen's fundoplication. Nissen's fundoplication is a 360-degree wrap. The myotomy should be at least 5 centimeters onto the esophagus, extending onto 2 centimeters on the stomach, and possibly longer. Submucosal endoscopic myotomy definitely shows promise, but we lack long-term results and comparative studies to make definitive statements. Thank you.